Hi, I'm R Walsh, and I will be speaking today about the realities of living with dyskinesia, how and when to treat it. So first, it's important to identify what dyskinesia is. Many of you are probably very familiar with it, but to make sure we're all on the same page, I think it's vital to see the picture, which is, of course, worth 1,000 words. And there are a few things I'll highlight here. One is you can see where my pointer is, that the dyskinesias are worse on one side versus the other, in this case, the right rather than the left. Number two, they're fairly subtle initially. You notice some movement in the hand that could be misinterpreted as tremor, but is dyskinesia. Three, when the patient starts to move and do something else, you see what's often referred to as overflow dyskinesia or activated dyskinesia, where the dyskinesias are more evident while the patient is trying to do something else. This is a very common phenomenon. Number four, you can also note that the dyskinesias are more pronounced in the legs than in the arms, in addition to being more prevalent on the right than the left. This is also not uncommon that different body parts will be more affected than others and can influence the movements that the patient has. And in addition, you'll notice as the patient starts to walk, and in a second they'll be walking down the hallway, that you'll see that the movements do influence the walking. So it's not just the presence or absence of dyskinesia that's important, or what side of the body or what part of the body is affected. It's the fact that they can influence the movements of the body in addition to their own presence in and of themselves. So that's a brief overview, which I'm sure all are familiar with, but it's important, I think, to set the stage for commonalities of what we're discussing when we mean dyskinesia. And this becomes important in thinking about what causes dyskinesia. And this is obviously a very busy slide. I'm not going to go through all of it, but the point is that there are a number of pieces to the dyskinesia puzzle. First of all, classically, it's been associated with the use of levodopa, but it's clear that that's not the only case. There are other medications that are associated with dyskinesia. And in addition, the progression of the disease itself, the progression of Parkinson's disease over time, is in combination with medication use what seems to underlie the development of dyskinesia. So it's not something that's just specific to the use of levodopa, which is why this talk is referring to dyskinesia rather than what's often called levodopa-induced dyskinesia. And furthermore, this slide emphasizes key points, which are there are changes that occur in the cells that come before the connection between cells, the synapse. There are changes that occur in the postsynaptic cell, the cell that comes after the synapse. And there are changes that occur not only with the neurotransmitters, the chemicals that go from one cell to another, but in the receptors that are involved with those neurotransmitters, and indeed things that are downstream from those receptors that mediate even changes at the genetic level. So the point of this slide, again, not to get it into too much detail, is that there are a number of different pieces to the dyskinesia puzzle that relate not only to the cells themselves and their degeneration over time in Parkinson's, but to the neurotransmitters that are involved, not just dopamine, but other neurotransmitters, which we'll get into a little bit later, as well as the receptors that interact with those neurotransmitters and the downstream effect of those receptors as well. Now, although this is a very complicated puzzle, it's important to note that because of this complication, it gives a lot of targets for therapies, a lot of targets for drugs and other therapies to go after. And that's important to keep in mind as we move through this talk. So now that we've briefly gone over what dyskinesias look like and what some of the causes can be in combination with the medication and the degeneration related changes in Parkinson's over time, when do we want to treat it? And this is right now, at least, largely very patient dependent. And this means something specific. So because every patient is different with Parkinson's, their symptoms are often different, including dyskinesia. The degree of dyskinesia, the presence or absence of dyskinesia, the severity of dyskinesia, the timing of dyskinesia, all of those are variables and influence the choice of treatment. And in particular, the majority of dyskinesias, not all, but the majority occur typically at the peak of the medication dose, meaning that the dyskinesia often occurs when PD symptoms otherwise are well controlled. The tremor, stiffness, and slowness of movement are well controlled. Yet that's when the dyskinesia often occurs. And this becomes an important issue to consider in the treatment of dyskinesia, because we want the medication effect for the tremor, stiffness, and slowness to be maintained, but we don't want to do that with the dyskinesia. So ideally, we can divorce the dyskinesia presence from control of symptoms. And this is very tricky to achieve in some patients. And that delicate balance between controlling the Parkinson's symptoms and controlling the dyskinesia is important. And then the key overarching theme, and what makes it even more patient dependent with regard to treatment, is how problematic are the dyskinesias? How bothersome are they to function of the patient and or quality of life in the patient? And these, again, are heterogeneous. These aren't one-size-fits-all answers to patients. Some patients have severe dyskinesia, some have mild, some are very bothered with function and quality of life, some aren't. And all of those factors weigh in on whether and how to treat the dyskinesia. But furthermore, and further complicating this picture, is that there's a growing body of evidence to suggest that patients are often not self-aware of the dyskinesia. And this is fairly common, depending on the study that you look at. Anywhere from 30 to 90% of Parkinson patients will have a lack of awareness of the dyskinesia. And importantly, this may be a form of what's called anosognosia, that is, the lack of ability to recognize something. So it's not that the patients are minimizing the dyskinesia or don't care about the dyskinesia. It's because of changes in the brain related to, we think, the neurodegenerative disease over time that actually can prevent the patient, even when they want to, of understanding and recognizing the presence or absence of dyskinesia. And importantly, this can include a lack of awareness of the functional aspect of dyskinesia, meaning how much functional impact dyskinesia is having can be challenging for patients to understand, again, because of anosognosia, or the lack of awareness, not because they're trying to minimize them. And then lastly, as I mentioned at the beginning of the talk, it's important to distinguish dyskinesia from other movement symptoms. They can often be reported as tremor, but they're not, or other extra movements when they're not. And this is important because the changes that one may make with regard to the treatment depends largely on how convinced one is of the dyskinesia itself, meaning that there actually is dyskinesia present, which leads you down one therapeutic path, instead of whether it's tremor, which would lead you down a fundamentally different treatment path. So the key take home from this slide is that the dyskinesia presence or absence is variable, when it occurs is variable, how much impact on the quality of life or function for patients is variable, whether patients recognize the dyskinesia, including its functional impact, is variable. And dyskinesia can be misinterpreted either by the clinician or by the patient. So all of these pieces of this dyskinesia equation are very important to keep in mind when one is thinking about when to treat dyskinesia. And then finally, the question becomes how to treat it. Fortunately, there are a number of ways to try to treat it currently and that are on the horizon. So currently, there are pharmacologic approaches to treating dyskinesia. Typically, we consider the reduction, particularly of dopaminergic medication, because all pro-dopaminergic medication can drive and or cause dyskinesia. One can also consider the adjustment of the timing, the frequency, so you can lower the dose and space the doses out more, and that can have the beneficial effect of reducing the severity of the dyskinesia. There are also extended release formulations of a variety of Parkinsonian medications, and instead of having a peak trough effect, where at the peak dose of a medication you see dyskinesia, and then the effect wears off and the Parkinsonian symptoms come back, sometimes it's beneficial to use extended release formulations of medication so that you can avoid the peak dose and trough effects and the patient's symptoms are more stable, including the dyskinesia, throughout waking hours. And then finally, under current pharmacological approaches, are the use of amantadine-containing medication, both IR, or immediate release, and ER, or extended release. Again, the amantadine is the only medication that has an anti-dyskinesia effect. So rather than adjusting the current dopaminergic medication that the patient may be on, one can add to that regimen amantadine-containing medications, either immediate or extended release. And indeed, the extended release formulation of amantadine is the only medication that has formal FDA approval for control of dyskinesias. And then if the pharmacologic approaches are either not effective enough or not well tolerated, which unfortunately can be the case, that's when we start to think typically about advanced therapeutic options. That is, options beyond medications currently available to take by mouth. And these can include levodopa-carbidopa intestinal gel, so another formulation of levodopa-carbidopa that instead of being taken by mouth is delivered in a very steady fashion through a tube that gets surgically placed through the stomach down to the part of the intestine that takes the carbidopa and levodopa up. In Europe and other parts of the world, not currently in the United States, there's an apomorphine pump, so a dopamine agonist that can be delivered in a less pulsatile fashion. So again, trying to avoid the peak and trough effects of medication delivery, and that can help minimize the dyskinesia. And then lastly, deep brain stimulator surgery or deep brain stimulation can be effective not only from an anti-dyskinetic standpoint to control dyskinesia itself, but can also often result in reduction of medications that can drive the dyskinesia. And then finally, clinical trials are an important thing to consider for patients with dyskinesia. Fortunately, this space is very active from a clinical trial standpoint, and they include a number of non-dopaminergic therapeutic targets, including the neurotransmitters glutamate, which appears to have the majority of the effect of amantadine mediated through changes in glutamate, but also serotonin and adenosine, two other neurotransmitters that seem to be integrally involved in the presence of dyskinesia and the worsening of dyskinesia as the neurodegenerative process continues in Parkinson's disease. So usually by a combination of pharmacologic, advanced therapeutic, and clinical trial approaches, one can often have a beneficial effect on dyskinesia. So in summary, importantly, it's very important to identify dyskinesia, and thinking about the video that I showed, when anatomy is involved and how severe, and whether it's something that's not dyskinesia like tremor. In addition, recognizing the impact of dyskinesia can be challenging because patients may not have insight into the severity and functional impact of dyskinesia, and this needs to be determined and weighs in on the choice of dyskinesia treatment. When to treat dyskinesia is a moving target. As the disease changes and worsens, so do the dyskinesians, and so do the options one would consider. And finally, therapeutic approaches to dyskinesia are varied. There is a number of options that we've reviewed, both current medications and advanced therapeutic options, as well as clinical trials that are continuing to expand our repertoire available to address dyskinesia. So I hope this talk was helpful for you in considering both how and when to address dyskinesia, and I appreciate your time. Thank you.